Um, welcome, welcome you to the fourth day of the Karachi Urology Week. And we have had institutional rotation this afternoon at the Indus Hospital. This evening's program is focused on urolithiasis and on urethral stricture disease. So we have a couple of presentations on urolithiasis. The first one will be by Dr. Salman Al-Khalid from the Kidney Center, and he's going to talk about the complications, how to avoid complications during PCNL. This will be followed by a talk by Professor Papasaurus from Greece. He's a well-known person in urolithiasis in ULIS and around the world. He will also be part of our panel to discuss cases. Some interesting cases will be presented by Dr. No Buchholz, and the panel would include Zamari Nouri from Herat, Dr. Saida Kharour Kariev from Uzbekistan, Professor Papasaurus from Greece, and I will be helping with the presentation of Dr. No Buchholz. And following this, we'll have some interesting cases on urethral stricture disease with a panel of experts from Karachi, including Professor Ahmed Fawad, Professor Manzoor Hussain, and Dr. Aziz Abdullah. Yeah, great. So without any further ado, I would request Dr. Salman Khalid to please proceed with his presentation on how to avoid complications during PCNL. Dr. Khalid.
Thank you very much, Ahmad. And Bismillah Rahman Rahim. We'll be starting, as Ahmad mentioned, we will be talking about the various complications that can occur in PCNL and how to avoid them. It will be a 20-minute presentation, and hopefully we'll have a few minutes at the end, in which if there's any question that anybody would like to ask, anybody would like to share their experience, I would be happy to give some time. Okay, like any other surgery, you are all aware that PCNL again is an art. And we as surgeons are artists, aren't we? And being an artist, we have to perfect our art to the extent that complications do not occur in whatever procedure we are doing. But it's important that we understand that, that PCNL is honey. Whenever you go in search of honey or any other sweet thing or any other nice thing that you like, you need to be sure that you must expect to be stung by bees. And they also say that failure is essential. If your uniform isn't dirty, you weren't part of the game. So there's no procedure in this world that doesn't come with complications. It's our job as a surgical artist to ensure that these complications are reduced to a minimum. They can never be zero, but we can attempt to reduce them to a minimum. And more important, it is to be able to recognize those complications in time and to know how to handle those complications. You are a surgeon only if you know how to diagnose complications and how to handle those complications. Those people who learn the skills of surgery without learning or without being aware of the complications and without being aware of how to handle those complications are, in my opinion, incomplete surgeons. So let's all try to be complete surgeons and learn the complications and how to handle and how to recognize those complications. Now, you are all aware that the incidence of or the prevalence of PCNL is getting higher and higher. More and more patients are coming in for PCNL. And this is attributed not only to increased effectiveness of the procedure in achieving stone-free status, but also to a reduced mobility in current times. Over a period of time, and I'll show you some data from 10 years ago and more recent data, and you will be able to appreciate that the mobility has actually gone down in recent times. Now, just before we go on to the complications, a brief review of what are the guidelines for PCNL. When should you be doing PCNL? And I would like to bring your attention to the first and to the third point. Perform percutaneous nephrolithotomy as first-line treatment of stones more than 2 centimeters. This is a strong recommendation with fully backed evidence, level 1A evidence, which makes us do PCNL for stones which are more than 2 centimeters. But concentrate on point number 3 as well. It says perform percutaneous nephrolithotomy or retrograde intrarenal surgery for lower pole stones which are bigger than 1 centimeters, which are lesser than 2 centimeters. So stones which are even lesser than 2 centimeters, and provided they are larger than 1 centimeter, can be considered for PCNL or retrograde intrarenal surgery, since the efficacy of shockwave lithotripsy is limited. And for this, you really have to look at the kind of factors that are available for shockwave lithotripsy. And you are all aware that there are certain factors which are called favorable, and there are some which are unfavorable. And the points that you need to take into consideration are the density of the stone in terms of HU. In addition, the length of the infundibulum, the angle of the pelvic iliacal angle, and the width of the infundibulum. All these are factors which have to be considered before you embark upon lithotripsy for lower pole stones. And if these factors are unfavorable, then you can make a very good case for either PCNL or for retrograde intrarenal surgery. Now, this is some of the data from 2007, and comparing that to 2015, you would notice, and these are pretty large series. The first one was more than 1,500 patients, and the second one is more than 2,000 patients. You would notice that the stone-free rate has gone down according to these figures. But this is not surprising, because now people have become braver. They are taking on bigger and bigger stones, more complicated stones, and as compared to what they were doing back in 2007. And naturally, when you take on to larger stones with bulkier burden and multiple chelical, complete stag-on, you would expect that the stone-free rate would be slightly lesser. And for similar reasons, the transfusion rate is also slightly higher as compared to 2007, when they would try to stay on to just simple 2 centimeter stones, rounded pelvic stones with significant hydronephrosis, and would try and not embark upon the riskier stones. However, look at the other things. The secondary procedure rate has gone down from 25% to 16%. Overall complications have also gone down from 22 to 18%. And if you look at the major complications, and major complications are those which are more severe according to Clavian grade 3A, which has gone down from 3.7% now to 2.2%. Now, what are the predictors of complications? Can you actually predict whether the PCNL that you are embarking upon may lead to complications? And if you are able to predict, then you would be more cautious, you would be more aware, you would be more vigilant, and you would try and see what techniques you can modify so that your complications go down. And for that, studies have shown that the number of comorbidities where the stone is staghorn more than 4 centimeters, if they have untreated UTI, if your operating time is longer, and when you're going for an upper pole access, particularly in people who are above 55 years of age, these are factors which may be predictors of complications. And this is where you need to be more careful. There are other factors, for example, BMI, stone composition, presence of multiple tracts, previous PCNL that were considered. However, these factors were not associated with a higher complication rate. So what exactly are these complications? Some of the most common complication is fever, which is about 23%. You can encounter bleeding, and minor bleeding is common. It's seen in almost every patient, but bleeding which necessitates transfusion has been found in about 12%. Extravasation of urine due to injury to the renal pelvic system is seen in 7%. You can have transient ureteric obstruction from a small stone fragment or from a blood clot, which can cause delayed leakage from the nephrostomy wound. This is noticed in 6%. Other complications which have been found in patients with PCNL, some of them rare and some of them slightly more common, includes pleural injury leading to either a pneumothorax or a hydrothorax, or sometimes even a combination of pneumohydrothorax. Atelectasis and pneumonia can also occur. Paralytic ileus is known to happen. Sometimes your nephrostomy tube can get early dislodgement before you were actually planning to take it out. It gets dislodged. You can have leakage from the nephrostomy site, which is commonly seen for the first few hours in most patients with PCNL. But if it persists for more than a week, then that is classified as a complication. Urinary tract infection and sometimes even urosepsis is known to happen in patients with PCNL. Urinoma can happen. As I mentioned earlier on, sometimes you can have injury to the pelvic system. This injury can extend to the ureter as well. And in rare cases, even ureteral avulsion has been reported. Sometimes if there's mucosal injury, especially in stones which are impacted in the pelvis, and sometimes you would notice that these stones are actually stuck to the pelvic wall, and in trying to dislodge them, in trying to take them or remove them from the pelvic wall, you can have injury resulting in fibrosis, causing uretropelvic or sometimes ureteric stricture formation. Bowel and visceral injury is also known to happen, and stone extrusion is also seen. Now, sorry. One of the largest series of studies was the CROWS study, the Clinical Research Office on Endourological Surgery, and they did more than 5,800 patients. This was reported back in 2012, and the overall complications that were reported, and this was a multi-center study from almost all major countries of Europe and some other countries as well, and the overall complications that were reported was about 21.5%. And they did a Clavian grading. Grade 1 was 11%, grade 2 was 5.3%, grade 3 was 3.6%, grade 4 and grade 5 were very uncommon. So coming on to complications, one of the most common complication, as I showed earlier on, is a febrile complication. And this can be due to either SIRS or UTI. Large stone size, as I showed earlier on, stones which are bigger than 4 centimeters, and people or patients who have got previous UTI are the main predictors of SIRS and UTI, whereas having a high normal albumin is considered as a protective factor. Now, following PCNL, SIRS or systemic inflammatory response syndrome is considered if 2 or more of the following features are present: a temperature more than 38 degrees Celsius or less than 36 degrees, a heart rate more than 90, respiratory rate more than 20, PSCO2 of less than 32, which indicates that the patient is breathing rapidly and is blowing out his carbon dioxide, a white cell count of more than 12,000 or less than 4,000. Any of 2 factors or amongst these factors if present would come under the label of SIRS. Now, you all know that screw white stones actually have bacteria growing in them, and these bacteria can sometimes form a biofilm around themselves, which protects them against antibiotics. Another thing it does is that it makes the urine appear falsely sterile. Normally, the urine that we take preoperatively is urine passed per urethra, and we all do cultures before embarking upon these kind of surgeries. And if the culture is positive, it is always advisable, strongly advisable, that these patients should be treated with adequate antibiotic until they become sterile. But sometimes, even though they are sterile, but studies have shown that when you do a puncture and you take the urine either from the pelvis, or some studies have shown where they have actually sent fragments of the stone for culture, these pelvic urine and stone cultures sometimes grow organisms against whereas the urine culture that was sent was sterile. So this again is evidence that with obstructed systems you can still have infection, and these bacteria which are in the renal urine or within the entrapped within the stone can be released during surgery, and this is what causes SIRS or UTI. And that's why it's advised that when you are doing a PCNL and your initial puncture reveals frank pus, for example, even if your urine culture was negative, if your if your initial punctures reveals that there's frank pus in the system, it is advisable to abort the surgical procedure at that time, leave a nephrostomy tube inside, allow the system to drain out, give them a course of antibiotic, let them become sterile, and then proceed with PCNL at a secondary date. Otherwise, the risk of developing SIRS or UTI or even severe urosepsis is quite high in these patients. Large stones carry a higher risk, and the recommendation is that all patients who are having large stones should, even if they are sterile on their cultures, should have a course of at least 2 weeks of antibiotics, so that whatever penetration can happen into the stone or into the pelvic urine will make the bacterial burden reduced, and that would help in curtailing or reducing the incidence of SIRS or UTI. Sorry. Why is this stuck up? Just give me a second. I think my slide is stuck up for some reason. Oh, strange. Where's my app? Okay, if you could give me a few minutes, let me switch it off and then I'll come back in 2 minutes time, okay? I think my laptop seems to be hung for some reason. I don't know why. I'll come back in 2 minutes.
Hi, Thanos. You're all set?
Hello.
Hi, good to see you.
How are you?
Long time.
Yes, yes, yes. How are you? Everything fine?
I'm great. Wonderful. So
You look great. You look great. Well, you
thank
look
you.
great.
I'm a laborer. I'm just working, sir.
Yes,
Good.
of course.
So I hope you're all set with the presentation. You are next.
Yes, of course, of course.
So in the
Thank
next
you.
10 minutes. Great.
Yes, yes, great. Thank you.
Right, there seems to be good participation, Ahmad, here.
Sorry, Zafar, come again.
I said there's good participation here.
It is indeed 30 people already joined in, and it grows with time. People are coming back from work. It's 5:30. It's almost 5:45 in Karachi at the moment.
That's right. So Salman's slides got stuck, so
Yeah, I mean, the morning session, afternoon session was good. You must have.
I'm tired from speaking for 4 hours non-stop.
I did the same thing on Tuesday, 3 hours
Non-stop.
Yeah.
I'm back.
Good.
Great.
Okay, can we start screen sharing? Just give me a second, please. Which one is it? No. Just a second, please.
Hemant, first you'll have to open the presentation and
Yes,
then
that's exactly what I'm doing. That's what I'm doing. Okay, is my screen visible?
no, not yet.
It should be. Not yet?
No,
Okay, let's see again. Yeah, now it should be.
no, not yet.
Yes,
Yes,
now it is.
yes, now it is.
Okay, sorry for the delay. Okay, let's move on. Okay, we had just been talking about the febrile complications. Another very important complication that we all need to be very cautious about is bleeding complication. And this acute hemorrhage can happen due to injury to a great vessel or to the main renal vessel, but this is extremely rare and it is said to be less than 0.5%. More frequently, you have injury to the segmental vessels. And if you look at the anatomy, if you can see what I'm trying to show here, this is a cross section of the kidney, this is the pelvis, and this is the posterior calyx and the anterior calyx. These are the posterior segmental artery, and this one here is the anterior segmental artery. And then this branch gives off the interlobar branches. And these interlobar branches, if you look carefully, are just on either side of the infundibulum of the calyx. And this is where injury to the segmental, interlobar arteries can actually happen if your puncture is not done correctly. What one should try to do is that access the collecting system from along a line from the infundibulum into the fornix of a posteriorly directed calyx. This is the line that has been shown, and one should aim for this line, which is running along the inside of the infundibulum and the calyx, to direct it towards the renal pelvis. If you try and stay in this plane, you would be avoiding these vessels which are on either side. And that's why it's very important that you have a very clear picture of the calyceal system, and you need to have a C-arm which is positioned in such a way that you can have a proper spatial orientation of the calyx. And only if you have a proper spatial orientation of the calyx, the posterior calyx is identified, and then you need to puncture or make your puncture in such a way that you go to the center of the calyx and avoid the lateral margins of the calyx. Now, the bleeding that happens in PCNL can be from the tract. Sometimes if you are very unlucky, you can hit a vessel right at the skin stab which you are giving. And these subcutaneous vessels can sometimes be very troublesome. However, they are easily controlled. But sometimes the bleeding is coming from deeper inside. It could be coming from the renal capsule or coming from the renal parenchyma itself. And when it's coming from the parenchyma, that is where you have more problems, because these are more difficult to control since it is coming from a larger branch, either a vein or the interlobar artery. If it is mild to moderate, if it is mild, you can progress with your surgical procedure and try and complete it as early as possible. But sometimes it becomes more troublesome, and that's when you have to adopt or you have to take up some techniques which can control the bleeding. The best or one of the easiest way is to tamponade it with the balloon dilator. You know which balloon dilator I'm talking of? These are the nephrostomy tract balloon dilators, which are sometimes used in place of Alkin's dilator. The Alkin's dilators are the serial dilators, the metallic dilators, which are commonly used. But now a lot of places are using the balloon dilators, which is also known as the Nephromax. Various companies are manufacturing it. And this is a single step or a one-step dilator in which you introduce the collapsed balloon over a guide wire. And once your the balloon actually is quite long, it's about 11 centimeters in length, and it is positioned from inside the pelvis up to the entire skin incision. So these dilators, they are normally used for creating a tract, but they are very helpful when you want to tamponade the bleeding, because it can tamponade the bleeding coming from the tract, coming from the renal capsule, coming from the parenchyma itself as well. If, however, you do not have a balloon dilator available, then the simple endotracheal tubes that you have, number 5 or number 6 endotracheal tubes are small enough. And if you have seen endotracheal tubes which are used by the anesthetists, you will again recall that they have a cuff, which is not like a Foley catheter rounded balloon type cuff, but it's a long cuff which measures about 4 to 5 centimeters. And these cuffs can then be positioned according to where you are expecting the bleeding coming from, either within the parenchyma or the capsule, or if it's coming from the tract. And that's where you can place this balloon, these endotracheal tubes, inflate the balloon, and that balloon will itself provide adequate tamponade. Even if that is not available, then a large bore nephrostomy or a 24 or 26 nephrostomy tube can be placed, and this can also act as a tamponade. You need to give them a lots of IV fluids, and sometimes even mannitol can be given. That will help flush the tubules and keep the tubules from going into shutdown. Delayed hemorrhages can also happen, and these delayed hemorrhages are seen in about 2% of people. These delayed hemorrhages occur more commonly if there are multiple failed punctures, also seen more frequently with upper pole access. Unfortunately, inexperienced surgeons is again one of the factors which can lead to significant hemorrhage. Single kidneys, large stones, access into the system through an atrophic portion of the parenchyma are all factors which can lead to significant bleeding. If the tamponade works, that's good. Sometimes these patients who come back to you with secondary hemorrhage, you need to be sure as to what is the cause of the secondary hemorrhage. The secondary hemorrhage can sometimes be due to infection, in which case once you have sent off a culture and they have other signs of fever, UTI, you need to keep them under observation, give them adequate hydration, put them on systemic antibiotics, and see if the infection can be controlled. And often this is helpful in controlling the hemorrhage. But on some occasions, the bleeding is coming not from infection, but from injury to the blood vessel, which could have formed an arteriovenous fistula or a pseudoaneurysm. In those cases, your conservative measures will not be able to control the bleeding. And this is the situation where you need to send them for angiography. Angiographic examination is one of the very helpful procedures in such patients, and the success rate that has been identified in good centers where they have got expert interventional radiologists is about 91%. Rarely, very uncommonly, the angiographic embolization fails, or especially if the angiography does not show a bleeding at the time that they're doing the angiography, in which case the interventional radiologist may not know exactly where to embolize. And these are the cases which will come back to you with a temporary stoppage in bleeding, but the moment they land back in the unit, they will again start to bleed. And this is where sometimes you have to embark upon surgical exploration. Now, renal collecting system injury. This happens in about 8%. And it results in extravasation of the irrigating fluid because the fluid goes out of the system and can get absorbed. And this is a situation which is almost similar to the TUR syndrome. However, again, it's important to note that the fluid that you use has to be saline. Long time ago, when people were not aware of this, there are initial reports where they have used distilled water, for example, and absorption of distilled water led to a situation which was very similar to TUR syndrome. But for the last several years now, everybody uses saline. And with saline, the absorption of saline does not cause a major disruption in the hemodynamic parameters or in the electrolyte balancing. But if there is extravasation due to injury, and this usually happens when you overshoot. Remember, once you've got your dilator in position, once you've got your guide wire in position, you need to be sure that the guide wire is in such a position that your tract lies in line with the pelvic calyces system. And once you have inserted the olive tip or the balloon dilator, make sure that you are sure that the olive tip, if you're using an Alkins dilator, or your balloon one-step dilator, or the other dilators, one-step dilators which are available, are not going beyond the visible pelvic calyces system on the fluoro, because only if they overshoot, that's when injuries happen. With the commonly used metallic dilators, the Alkins dilators, you need to have a very good control of the olive tip, because sometimes you have to use force to introduce the metallic dilators. This is also the force that you use has to be a very controlled force. Don't overshoot, because that is what causes injury. Certain intraoperative signs of injury include when you put your nephroscope in after the implants, you would see structures which are not looking like the calyx. The smooth wall of the calyx or the pelvis is not visible. In fact, you see strands of tissue, or sometimes you even see the perinephric fat. And if you see this, if it's a small puncture hole that you are seeing, it doesn't make too much of a difference, and you do not need to stop your procedure. But if there is, larger injury, you would need to stop immediately, put in a nephrostomy tube, and sometimes leave a DJ stent as well. And sometimes you have to put in a perinephric drain as well. Now, pleural injury. This is again something that we all need to be very careful about. Overall, 0.3 to 1%, and it is mostly associated with supracostal puncture, and the risk of injury with supracostal access is 16%. However, even with infracostal access, it is known to happen in about 4.5% of people. And once it happens, if it's a very small puncture, sometimes you can get away without putting a chest drain, but more than almost 2/3 of patients will actually require a chest drain. Now, this figure that I'm trying to show here is a child's picture. And what I'm trying to show here is two very important things. Those of you who are involved in putting in chest tubes have to learn the art of putting in chest tubes, because placing a chest tube and directing it actually depends on whether they have got a pneumothorax or they've got a pleural effusion. If you look at this on the right side, this is a tube which is directed upwards. And this is directed upwards because this is the direction you need to place a tube in when you are draining a pneumothorax. This has not actually reached the upper part, the apex of the lung fields. Normally, in pneumothorax, you would see that the amount of air that escapes begins to collect from the apex, and then it goes downwards. So you need to have your tip of the chest tube positioned in such a way that it's near the apex. On the other hand, if you are draining a fluid collection, like in hydrothorax, then where does the fluid accumulate? The fluid accumulates in the lower part, and it basically accumulates in the posterior costophrenic recess. This is the space at the back side between the liver elevation of the diaphragm and the rib cage, and that's why on the left side you would see that this is a tube which is placed posteriorly and inferiorly. It is directed towards the costophrenic recess. So that's why the specific instructions are, when placing a chest tube, look at the X-ray, see whether it's a pneumothorax you're trying to drain or it's a hydrothorax. For pneumothorax, you go up and anteriorly. For a hydrothorax, you go below and posteriorly. When should you actually suspect that there is a pleural injury? Intraoperatively, if the anesthetist reports that there's difficulty in ventilation, the ventilatory pressures are going up, or the saturation is not being maintained, this is the situation where you will need to consider that possibly a pleural injury has happened. And sometimes in the post-operative period, you would notice that the saturation is not going down, is not being maintained. The patient is requiring supplemental oxygen at a high rate. They're having difficulty in breathing, or sometimes even they can have fever. In such a situation, you need to get a chest X-ray immediately and make a diagnosis as to what it is. Now, what are the preventive techniques for pleural injury? As I said earlier on, the incidence of pleural injury is higher with supracostal access, and that's why if you can avoid a supracostal access, that is the best preventive technique. However, there are going to be situations when the best access is through the supracostal access, and that's why you will have to do the supracostal access. In such a situation, it is advisable to stay lateral to the erector spinae, because the more medial you are, remember the pleural reflection is at a lower level in terms of the intercostal space medially, and as you go laterally, it acquires a higher intercostal level. So the more medial you are, the higher the risk of injury. The more lateral you are, especially if you are lateral to the rectus spinae, then your chances of puncturing the pleura and causing lung injury becomes less. Another point to be noted is when to puncture. You have to coordinate your puncture with the anesthetist, that during the ventilation, the bleeding, the puncture happens at the end of expiration, when the lung is collapsed, not when the lung is fully expanded. Because when the lung expands, it pushes the pleura down, and that's when the chances of puncture become more likely, whereas in expiration, it becomes less likely. Sometimes this is difficult, and another way of controlling or reducing the chance of injuring the pleura is to, first of all, make a lower pole puncture, gain access into the pelvic system. You may not be able to reach the stone, but your Emplart's tube will help in controlling the kidney and pulling it down. This is called renal descensus. And by pulling the kidney down, you can lower the level of the upper calyx, and that will help in acquiring a supracostal access, which is not going beyond the 11th rib. Anytime you go beyond the 11th rib, you are almost certain that there will be pleural injury. So stay max between 11th and 12th rib. Do not go beyond the 11th rib. What about adjacent organs? The spleen and liver can get injured, but very rarely, only if there is splenomegaly or if there's hepatomegaly. More commonly, the colon is injured in about 0 to 1% of patients, and the risk is much higher in left-sided stones, in the female gender, patients who are lean and thin, horseshoe kidneys, because horseshoe kidneys, remember, are more anteriorly placed, or if there's a history of previous bowel or renal surgery, in which case adhesions and reflections of the peritoneum may allow the bowel to become retrorenal, and this is what predisposes to organ injury, especially the colon. A careful review of preoperative cross-sectional CT, especially when you're dealing with horseshoe kidneys, is important, so that you're able to identify if there's any retrorenal colon, and if there is, then your puncture has to be guided in such a way. Use an ultrasound to guide, or use a CT to have your marking, so that you do not go through the colon. If, however, accidentally you do puncture the colon, then the best thing is to leave a nephrostomy in the colon, withdraw your nephrostomy, place in the colon, and place a jeju stent. If the detection is late, then you may require a diverting colostomy. Now, renal dysfunction after renal dysfunction after PCNL is common. However, you can sometimes have a transient increase in the creatinine, and this occurs in about 1% of patients. And this 1% of patients where you have a transient increase in creatinine is similar to what happens in after ESWL, for example. And this is particularly related to the state of hydration that the anesthetist has maintained during procedure. If they have underinfused, or you have used certain drugs which may have been nephrotoxic, then the chances of a creatinine temporarily rising is higher. Very clear studies where they have used preoperative and postoperative MAC3 to look at the differential renal function has confirmed that there is usually a very stable differential renal function after PCNL. Scarring is known to happen, but this only happens in about 1% of patients, even with multiple tracts. Renal dysfunction, however, can happen secondary to other complications like ARF, which happens after there's been a massive bleed, or there's been a significant bleed which has not been adequately compensated, and sometimes when the angioembolization that you have done for control of hemorrhage has caused significant renal parenchymal injury. Position-related complications are known to happen. Various positions are adopted for PCNL depending upon the surgeon's choice. Options between supine, prone, modified supine, and there's so many other positions which are currently used by different surgeons. Complications are rare. Important points that you have to note are proper padding of pressure points. As you can see in this diagram, all these pressure points have to be adequately padded so that there's no injury to these points. minimize the stretch, because especially of the extremities, these can cause peripheral nerve injuries. The head and the neck position has to be very carefully monitored, especially when doing prone PCNL. Remember, we do the retrograde in the supine lithotomy position, and then we turn the position to a prone. That's when the anesthetist has to very carefully handle the head and neck so that you do not cause any significant injury. A care of obese patients and patients with contractures, especially with care, so that these are patients who are more likely to develop complications related to position. Now, death is also one of the complications that can happen in any surgical procedure. It is, however, quite rare after PCNL. And if you look at the huge CROSS series of about 5,800 patients, only 2 grade 5 Cleveland, which means death, happened, and this comes to about 0.03%. If it occurs, it is usually secondary to complications like pulmonary embolism, myocardial infarction, severe sepsis, and these are all complications related to the comorbid situation of the patient, and that's why a preoperative screening, anesthesia evaluation, and where required, a cardiac and a pulmonary evaluation is necessary before you book these patients for your surgical treatment. In conclusion, what I would say is that PCNL is a well-tolerated procedure with low risk of major complications or death. Advancements in technology and progressive perfection of technique will likely further decrease the complication rates. It is important to understand, and my residents, please understand, that PCNL is here to stay. And with the stone burden of Pakistan, it is an essential art to be mastered by every urologist who calls him, every person who calls himself a urologist. If you do not master PCNL, then you will be left out with almost 50% of the surgical load that is seen in urology. Most important consideration for a successful outcome is correct selection of patients. Not just the selection, but the planning is also very important. When you do a retrograde, look at the detailed anatomy of the pelvic system, make a decision as to where the most convenient and the safest puncture would be so that you're able to achieve maximum clearance of the stone. A well-standardized technique and a careful post-op care is essential for early detection and control of complications. With that, I come to the end of my presentation, and all of those who are preparing for the fellowship exam, my best wishes, and we hope to see you soon in the next exam. Thank you very much.
Thank you, Salman. There were some questions on the chat, which we have answered. And if somebody has more questions for Dr. Salman Al Khalid, please post them on the chat. I would now request our next speaker, Professor Papasaurus, who will be speaking on best management for 10 to 20 millimeter contemporary management of symptomatic 10 to 20 millimeter kidney stones. So thank you for joining us all the way from Athens, and all yours.
Good afternoon from Athens. It's a real pleasure to be part of this excellent session, and I would like to congratulate the association for organizing the 10th Karachi Urology Week. The scientific level is very high, and I would like to especially thank the chairman of the session and Professor Arthur for the kind invitation. Also, it's a great pleasure for me to see the name of Noor Buchholz that will follow. Both Professor Arthur and Dr. Buchholz are very good friends of mine, and for me, it's very important to be around. So I'm not in Santorini, unfortunately. I'm in Athens, and Greece is actually in the middle of West and East. We are actually the capital of the Balkans, and we collaborate with our fellow neighbors. We have formed the Segur group for urolithiasis, and we have published a lot of work regarding urolithiasis in the Balkans. As in Pakistan, the Balkans are an area where urolithiasis is quite common. So we have the problem of planning the treatment of our patients, and we have to decide which of the standard three modalities we're going to choose. From the SUT publication, we know that we have more interest for PERC and for REERS, especially REERS flexible uteroscopy has great achievement with equipment, but also REERS and PCNL are very popular. With ESWL, we have less interest, but ESWL has also advantages in specific patients. For example, now with the COVID pandemic, where the programmed stone treatment was actually frozen, we had to treat more patients with ESWL. So there are indications for ESWL also, especially during a crisis like this one. We don't treat the stone, we treat the patient. So when we have a patient with a renal stone, we have to take into consideration many factors. Factors that have to do with the stone, with renal anatomy, and with other problems of the patient. The size is something very common to take into consideration, the number of the stones and the composition. Also, it's important to know if we've got obstruction, hydronephrosis, if we have other abnormalities like a PUJ stenosis or a diverticulum. And of course, it's important to know if the patient has a UTI, if he's very obese, if he is on anticoagulant medication, etc. So don't forget all these parameters when you're going to decide how you're going to treat your patient. Now, the trend for urologists like myself that have been trained with fellowship programs is to use more delicate endourology procedures like PCNL and REERS to treat stones. A urologist that has not been trained to do advanced endourology may recommend ESWL, for example. So it's important to recommend to your patient what is best for him and not what you can do better. So it's more decent to refer a patient to a colleague that, for example, can do a PCNL if PCNL is the indication. Let's go to our main topic, the management of a symptomatic 1 to 2 centimeter kidney stone. So we start with the fact that it's a symptomatic case. So it's not a case where you can wait for a long time because you say it's not a big stone, I'll treat it after weeks or months. The patient is symptomatic. So that means that probably he has a renal colic that cannot be treated with regular painkillers. So usually we administer our anti-inflammatory medications, we may give opioids, and if we've got a symptomatic case, for example, we've got upper ureteric stone obstructing, if this 1 to 2 centimeter renal stone has been stuck in the UPJ, then probably we have to interfere and we cannot just give painkillers, either anti-inflammatories or opioids. So we need to go ahead with renal decompression in order to have the patient asymptomatic. So first we need to treat the symptoms of the patient. I don't actually say that all symptomatic cases should be operated from the very beginning, but for sure, we need to treat the symptoms of the patient. And there is a percentage of cases where we need to interfere. We need to go ahead, either, for example, putting a JJ stent or even a nephrostomy, or going ahead straight away with our ureteroscopic treatment. So the symptoms should be treated. You cannot plan anything if you don't have the patient symptom-free. Of course, we're going to treat when you have done your proper imaging. And I'm just putting this X-ray KUB to show you that you cannot say that proper imaging is an X-ray KUB. In the past, they were doing an X-ray KUB and they would refer a patient for ESWL. But here is a gallbladder stone, and you understand that you should not go ahead with shockwave lithotripsy. So it's very, very important to have the proper imaging before going ahead with the management. Again, a gallbladder stone where you can see that the ureteric catheter is at the upper pole and there is a distance with the stone. So this is not a kidney stone. The best imaging for sure is CT, the unenhanced CT. And if you do 3D reconstruction, this is even better. Of course, we've got the disadvantage of radiation exposure. And you can see here the upper ureteric stone and also some calyceal stones. For sure, it's good to have proper imaging. So we may proceed once we have dealt with the symptoms of the patient, and we know that it's a 1 to 2 centimeter kidney stone. Will the size actually make quite difference? 1 to 2 centimeter kidney stone is in our guidelines. Here is the algorithm from the EAU guidelines, our European Urology Bible, where you can see that for 1 to 2 centimeter, actually we've got lithotripsy, shockwave lithotripsy, or endourology. There is an asterisk which has to do with lower pole stones, but you can see here that for 1 to 2 centimeters, the size of the stone cannot actually interfere a lot with the solution that you're going to choose. So 1 to 2 centimeters is a debatable size. So you cannot just take into account the size of the stone for this case. It's a kidney stone, okay? It's not an upper ureteric stone, it's a kidney stone. So it's good to know where this stone is exactly. Because as I told you before, this asterisk has to do with the lower pole anatomy. For example, if it's a stone in the lower pole, you wouldn't do easily shockwave lithotripsy. So you need to know where exactly the stone is inside the kidney. You need to know the renal anatomy. Of course, you won't proceed CT 3D in all cases, but it's good to have in your mind exactly the renal anatomy. And why I'm saying this? Because there are cases where you may have stones in difficult calyxes, like this one. So there are different imaging modalities, and with a CT, you may have some help what you're going to do, how you're going to treat your patient. These are some difficult cases where you can see here that we have different images with different cases in order to do either a PERC or a flexible ureteroscopy treatment. And this is an even more difficult case where you would go ahead with a PERC with multiple punctures. So it's very important to understand where this 1 to 2 centimeter kidney stone is exactly. And of course, it's different if it's in the upper pole, in the middle pole, or in the lower pole. And that's why in the guidelines, it's mentioned if we've got favorable or unfavorable factors for shockwave lithotripsy. So if we have unfavorable factors, then we should go with endourology. What endourology means? It's RIRS and PERC. So these are the factors that will actually interfere with the success of ESWL. And if we've got a steep angle between the lower calyx and the ureter. What does steep mean? It means less than 30 to 45 degrees. If the calyx is long, what does that mean? Up to 5, for example, centimeters. If the skin to stone distance is quite long, more than 8 to 10 centimeters. If the infundibulum is narrow in the lower calyx, that means less than 5 millimeters, or if the stone is quite resistant, like in the monohydrate calcium oxalate stones, the monohydrate is more resistant in comparison with the dehydrate, or if you've got a cystin stone. So these are unfavorable factors, and if this 1 to 2 centimeter stone is in the lower calyx and we've got these parameters present, we shouldn't go ahead with ESWL. And here is the angle. Usually we take this line with the line of the ureter, and this is the steep angle that it could impair the success of ESWL. And this is actually the angle that we measure. There are other proposals, but this should be the angle that we should measure in most cases when we plan our operation. Here you can see not a very steep angle. Probably if we've got a stone here with this wide infundibulum, the stone fragments could actually move. Here we've got a more steep angle. As you can see, it's not so easy, and the infundibulum is quite narrow. So it's good to have this information before we suggest shockwave lithotripsy. Of course, in addition to the position of the stone inside the kidney, there are special cases where, for example, we may have a stone in the reticulum, we may have a stone in a horseshoe kidney, or a pelvic kidney, or in a incontinent reservoir. This is not a stone in the kidney, but there are special cases where we have to treat with different treatment options. I'm saying this because it's not only if we've got symptoms, it's not only if we've got the size of the stone or the fact that we have a stone in the kidney. For example, we've got this case where we've got a stone in a diverticulum. You can see here, that's the lower pole diverticulum. Usually we've got diverticulum in the upper pole and usually right-sided. And of course, children are special cases where we take into consideration size, we take into consideration also the household units, and we know that stones inside the kidney of a child are treated easier with ESWL in comparison with elderly patients. Now, we could have information useful with the composition of the stone. And of course, we need to know if the stone is radiopaque or radiolucent. A common problem is to do shockwave lithotripsy with uric acid stones. If they are 100% uric acid stones, you need to have the ultrasound assistant to do ESWL. And it's easier if the stone is in the pelvis. But if you are not very familiar to perform ESWL, then with ultrasound guidance, then it's actually better to do RIRS. If we've got stone analysis from other operations that the patient had, it's good to have the information if the stone is, for example, infectious stone and it's too white stone, or if we've got the monohydrate stone or the dehydrate stone. These are information useful for us. We measure the household unit with the CT. We may ask this if it's not reported, and we know that if it's less than 1,000 household units, then the success of ESWL would be better if it's more than 1,000 household units. Regarding ESWL, we've said most of the things that we need to know. There are not many contraindications, but we need to be aware of the absolute contraindications like pregnancy, bleeding diastasis. Very important, the uncontrolled UTI, because if you have the risk of urosepsis and you go ahead with ESWL, the patient may die at the end. That's why in our department, where we have 2 lithotriptors, we are the only center in the Balkans with 2 lithotriptors, we always ask for a urine test before going ahead with ESWL. Now, in case we have this size of stone, and it's a stone that is actually quite hard, more than 1,000 household units, then maybe we could go ahead better with a PERC. And we have this publication by Arthur Smith several years ago. Another issue that we need to take into consideration is if the PERC could be feasible. Now, for this size of stone, 1 to 2 centimeters, we could go ahead with a mini PCNL because it's actually not a very big size. And you could actually use several treatment lithotripsy modalities to treat this stone. Now, regarding mini PCNL, we have different sizes and different terms. For sure, it needs to be less than 22 French. And there are several proposals by many centers across the world. I don't know in your country if you perform many PCNLs. We have a lot of staghorn stones. We still do a lot of PCNLs, standard ones. In case we have to choose regarding the treatment modality PERC versus VIRS, we can see here that this publication from European Urology Focus, February 21, shows us that actually mini PCNL has a higher stone-free rate than VIRS if we've got a stone above 1 centimeter, and for lower pole stones also. So we could say for 1 to 2 centimeters, it's more efficient to do mini PCNL. Another issue is if we've got the risk of UTI, and if we've got risk factors of febrile UTI, which is worse, like preoperative pyuria, then again, the PERC should be the better option than go ahead with VIRS, because as we all know, when we use flexible uteroscopy to treat renal stones, and we've got a UTI, with increased pressures, we may have reflux and we may have bacteremia and urosepsis. So for these cases, again, PERC would be our option. Actually, the 1 to 2 centimeter stone, like this one in the pelvis, this is a 2 centimeter stone, is quite a straightforward PERC. Here we can see with our retrograde studies how nicely the system is seen, and for us it's quite easy to do a nice puncture. We don't use now blue dimethylene like in the past. We have a nice puncture with our wires. Always for younger colleagues, it's advisable to actually advance the safety wire down to the ureter. And these are the nice angulated open-ended uretary catheters to drag your wire down to the ureter. You may put a second working wire or stiffer one. This is actually step by step how you should start your cases. I remember Noor was always teaching us that you should start with 1 to 2 pelvic stone when you are in the beginning of your career. The balloon dilatation is again straightforward. You have to be aware, of course, of the full dilatation of the tract, and it's easy to do lithotripsy for this stone. This is the standard PCNL. Again, if you have the ability and equipment to do a mini PCNL, you could go ahead. For rears, there is a great fuss regarding the advantages that we have with the new scopes. Again, a safety wire is advisable to be inside when you're doing cases and you're not very experienced. The whole issue, of course, is to have the equipment and everything ready on your table. And now with our new digital flexoscopes, our job is easier because these new scopes are lighter, so it's easy for you to handle. You have less fatigue, you see better, you can zoom better. So that means that you can operate safer, more efficiently, and quicker. So we have the consideration for our residents to operate with our flexible scopes, especially if we've got only one flexible scope in our department, because we don't know if this scope may break, how many cases we can do. And now there are studies that actually have demonstrated that you can use a flexible scope for up to 27 cases or up to 20 cases, especially in departments where many surgeons and inexperienced surgeons are using the reusable scopes. That's why if it's possible to have the single-use disposable scopes, it's quite good. We have different scopes in the market. More and more scopes are coming, and the price could actually be less. However, we need to balance the cost effectiveness of the disposable ureteroscopy, because we need to know the break-even point between the reusable and the single-use flexible ureterothripsy. And the message is, if you are doing less than 100 cases, then you could have cost effectiveness with the single-use scopes. But if you are a high-volume center with more than 100 cases per year, then the reusable ureteroscopy is more cost-effective. Here is a recent publications with the advantages and disadvantages of the single-use ureteroscopy. Of course, the big disadvantage is the cost. Otherwise, it's good to have a disposable scope in your department for your residents to be trained. Also, there are infectious cases. We have several with COVID that we have to treat, and you don't have to be anxious to maintain and repair your scope. For sure, you won't cancel the case if it breaks down. I told you before that equipment is very important, so you need to have disposables, wires. You need to have also several techniques to enter your ureter if you're going with rears. You may need to dilate the intramural part of the ureter, but this is basic law that I'm sure that you know. Don't be afraid to balloon dilatate the lower part of the ureter. But if you've got any problem, if there is any issue, just advance the stent and come back a few weeks later. It's better to be on the safe side. So these are the accesses, and we need to use them when needed. The trend now is to use less the accesses because there are several limitations, and we may end up with complications if we are not very cautious when we advance our accesses. Personally, use the thinner accesses, 9 to 11 French or 10 to 12 French. And if I work in the kidney with low pressure, I'm not so anxious to have an access when I'm performing rears. Of course, we need to have stone fragments for composition and stone analysis, and culture. So we need to grab the stones from the kidney. Better to use graspers and not the old baskets, because if you've got a basket stuck in the kidney, then you're in trouble. So we need to have also this equipment when we are performing rears. This is an indication for a disposable rears because we've got a lower pole stone. And if we are using this for a long time, our disposable scope may end up with problem. We don't care, but if we've got our one and only usable scope, then we may end up with a broken scope. Of course, it could be useful to have virtual simulators to train our residents to perform a proper puncture during PCNL or rears. And we were lucky enough in London with Norbohost to have that simulator, the Eurowork Mentor. And we were completing several hours before we entered theaters. So the key to the success is to collaborate with experienced colleagues, learn tips and tricks, and go ahead on our own. So I would like, before concluding, to invite all of you to our 5th ESD conference in Athens in about 10 months. I have the privilege to be with Norbohost, the chairman of the ESD, the organizers, and our very good friend, Professor Afer, is also in our prestigious advisory committee. So please join either physically or virtually, because it's a hybrid congress, and I would be very happy if you could join us there. And you could also see the beauties of Greece. This is a picture from Athens, to be honest. So thank you very much, and stay safe. It was a real pleasure. Thank you.
Thank you very much, Thanos. It's a wonderful presentation. You very comprehensively covered the topic in 20-25 minutes. If you are available and not occupied elsewhere, we'd love to have you as a panelist in the next session, where Bocholt is presenting some of the cases. He is busy in the stent workshop, so his presentation is going to run. So we have a very elite panel for this next session. Sharif, can you please mount the presentation, Dr. Bocholt? Dr. Papasaurus from Greece, Zafar Zaidi from Karachi, Dr. Saida Haror Kariev, a very good friend and an endourologist from Uzbekistan. So it's good to see you, Papasaurus, and Zafar and Kariev, along with Dr. Zamari Nouri from Herat, Afghanistan. So it's good to have him. I think he is probably joining. So can we have his presentation? Sure. So this is an interactive, this is an interactive session. There will be poll in this presentation, and we will take opinion from our very elite panel. And so please feel free to cast your vote so that we can have some discussion on the practice pattern that you have, and in light of these international experts. So, Sharif, whenever you are ready with the presentation, please upload. having a little trouble with this presentation. I think it's a good opportunity. Let me ask one question to Thanos, you about this lower pole, and since the time that our Brazilian friend has described this lower polar anatomy some more than three and a half decades back, this is the time where we used to use a lot of IVUs before we do any of the interventional treatment for endourological intervention for stone disease. Now we use non-contrast CT invariably. So is there a way, is some software that can help you in defining those infundibulopelvic angle and the calyceal anatomy?
Unfortunately, practically speaking, no. And it's a problem that we deal with every time. And sometimes we consent our patients for both operations. That means that we do retrograde studies. And if we believe that the lower pole anatomy is quite unfavorable for the success of rears, we could. So if you don't have any contrast, if your CT imaging has no contrast, it's difficult to be able to predict the width of the infundibulum. Thank you.
Thank you, Thanos. So I think we are ready with this presentation. So can you run it, please?
Assalamu alaikum and hello to Professor Hamad Ater, who invited me to give this presentation. I'm also saying hello to all my friends in the panel and salam to all my friends in the audience. And I'm sad and happy at the same time. Sad because we can't meet personally, which was always a highlight in the year's calendar, and happy that we at least can meet electronically and virtually. So without further ado, I'm presenting some interesting stone cases. Here is my disclosure. Some of the cases are by Professor Olivier Traxer. Otherwise, I have no disclosures to declare. So this is the first case. This is a 62-year-old healthy female. She is 164 centimeters in height and 72 kilograms heavy. She's absolutely asymptomatic, and on the ultrasound there was an incidental finding of a lower pole stone on the right, 14 by 10 millimeters. So what would be your preferred treatment mode for this stone? ESWL, B, PCNL, C, rears, or D, you would not treat this stone without further imaging. And please be honest, because sometimes we do treat stones without further imaging, don't we?
Hold the presentation, Sharif.
Now, this is the further image.
Right. So this is the poll result, and about a third have said PCNL, another third has said RIRS, and 40% have said they want to do more imaging. So my question to you, Professor Zedi, is that for a stone like this, and somebody who presents to your clinic with a plain X-ray KUB, and Thanos has also referred to this thing, what would be the next thing would you do before, say, if you want to treat this patient? Symptomatic stone and she needs treatment. What further imaging would you do?
Thank you, Hamad. I think in the days now, it's fairly rare to ask for an IVU or contrast study, and often we can make quite good judgment just by looking at a plain unenhanced CT scan. So in this particular case, from what I see on the plain film in the KUB, which looks like a stone in the lower pole in the area, I would ask for a plain CT KUB to start with. I'm also very interested to look at the anatomy of a spine, which is in a horrible mess.
Right. Dr. Karyev, would you do a
Yes.
plain CT or you would just do an ultrasound and proceed?
I think that the ultrasound is not enough to make the diagnosis and choose the treatment. We should prefer the CT scan and use the contrast medium. CT scan is give us many informations. First of all, the presence of stone density, and about distance from skin to stone.
Thank you. So can we proceed with this presentation?
And you can see here that there's actually no stone in the kidney. This is a gallstone. So good you didn't schedule this patient for urological intervention. And we go on with the next case. This is a 31-year-old female with the spina bifida, quite severe, as you can see. She's a complicated case with sleep apnea and multiple comorbidities. And she has recurrent severe urinary tract infections. And of course, what you can see here on the left side is a sizable stone. Now, do we need to treat the stone? Well, she has uncontrollable infections, so at least, if possible, we should try to treat the stone as a possible cause of the infections. So what would be the next step after you've seen this patient in clinic or whilst you were seeing this patient in clinic? Long-term antibiotic coverage and sending her home, chemolysis, a MAC3 scan to look for the kidney function, or a bedside ultrasound of the left flank.
So you can vote now.
Well, the correct answer would be the
Stop
bedside
the
ultrasound of the left.
Okay, so about 50%, nearly half of you have voted, and I will give another 5 seconds for the rest of you to vote. And then we can ask our panelists for comments. I think we can end poll and share results now. Great. Thanos, I would like your opinion. This is a difficult case. This is not something run of the mill. This is for specialized center, and people like yourself and Bochols are the one who should be dealing with this situation. So what would you do in a situation like this?
Yes, actually, as you understand, this is a complicated case with many problems, and the patient has COPD, so that means that it's not easy to perform your treatment management with general anesthesia. I would do a PERC. For example, I would do a standard PERC to be quick and be more familiar with the management, and I would do it under high regional anesthesia. So that would be my treatment option. Regarding the question regarding the MAG3 or the ultrasound, of course, the proper imaging is a CT and 3D CT with 3D reconstruction. The MAG3, just to say a comment, is not so useful if on the CT you see a quite thick parenchyma. So I wouldn't do a MAG3, either ultrasound. I would do a good CT and proceed with a PERC under high regional anesthesia. Thank you.
Do you anticipate any issues because of the anatomy? And would there be a situation when you would like to have a laparoscopic access before percutaneous access?
No, I believe that in this case, if you actually study carefully the 3D CT, you could change the position that you're going to operate. You can do this on a lateral decubitus or a supine position, but not on a prone position because the patient would have regional anesthesia. So you can change the position of the patient rather than go ahead with laparoscopy. But of course, if you're not confident to do PERC, you could have this option.
Right. You're mute, Ahmad.
Yeah, sorry. We can proceed.
So okay, I just want to add something here.
Yeah, sure.
Yeah.
Sure.
I think the choices here, which are not the best, but in the question here, yes, an ultrasound would help you to look at how the hydronephrosis is and what the cortex is like. But I completely agree with Professor Papasaurus that you need to have a CT scan because often there are viscera which would be in way of this, and ultrasound will not be able to show it. Now the problem is anesthesia. Otherwise, and just on the look of it on the KUB, you can look at it and say you can perk it, but you'll be quite surprised that the liver may be pushing across or some other organ is over there, and that's a huge problem with such severe abnormal spinal positions. It's a pretty high level spina bifida. She may not have much sensation in a lower urinary tract, and if she doesn't have that, I would be tempted to actually use an RIRS and actually be able to go in from below, if at all, depending upon, I know you have to see the patient, how she's lying down and what is the situation. But because she may not have any sensation, she may not even require anesthesia because look at the level of the spinal bifida, it's very, very high. So she may be all anesthetized below anyway. So those are options, but you do need to have very good anatomical positioning of where the stone is, where the other viscera is, what you have, and what positions you can do best with. So I think I think the choices should have had something better than what we have here in the 4.
Right. Let's proceed. Thank you very much, Zafar.
Well, the correct answer would be the bedside ultrasound of the left flank. And why is that so? Because we need to see whether we could have a percutaneous access to that kidney. And if we go back on the picture, then you can see if it were a right-hand stone, there would be no opening between the bones to go onto that stone whatsoever. So what would be your preferred treatment option? ESWL, retrograde intrarenal surgery, PCNL, or open surgery?
Okay, partly the question was answered by our panelists, but let's see the opinion. Next poll, Sharif. This has already been done. Yeah, please vote now.
Interesting. We have one gentleman
Wants to do
on open surgery.
Dr. Karyev, what is your opinion? There are 2 people who have voted for open surgery and lithotripsy.
I think that here is not enough information because before the shockwave lithotripsy, we should know about the condition of urinary tract lower than stone. If we will perform the shockwave lithotripsy, we can damage the organs around the kidney, and also we can observe the Steinstrasse. In the open surgery, about open surgery. I think that in centers where is it not enough experience with the rears PCNL, maybe performed open surgery if not have equipment.
Thank you. Let's carry on with the presentation.
Now, we opted for PCNL because retrograde intrarenal surgery in such a short person with deformations can be extremely difficult because of a very tortuous ureter, and there is usually no way to get all the fragments out, and it's very doubtful if the kidney is able to extract even powder after a laser fragmentation. So we did actually a PCNL on that patient and we got a stone free. Now this is a 40-year-old male, recently evaluated for recurrent headaches and vomiting for 6 to 8 months. There's no history of any abdominal symptoms or lower urinary symptoms. And there's a normal renal function. So have a look at that X-ray. And this is the CT scan. So on the left, you can see a bilateral empty renal fossa. In the middle, you can see a pelvic kidney with a lower pole stone. And on the right, you can see a upper ureteric stone in the same single pelvic kidney. So this is the side view. You can see the kidney with the upper ureteric stone, the lower pole stone, and the bladder in front of it. You can move the cursor. This is the bladder. This is the ureteric stone, and a bit of a Steinstrasse here, and there is the lower pole stone. Now, if we go through the CT scan, you can see here a kidney stone in the pelvic kidney on the left. And you can see the ureter stone in the upper ureter next to the bladder here on the right. So what would you do with these stones? ESWL, retrograde surgery, PCNL, or ESERS?
Share the next poll, please. It's for our audience to please vote. Can we have the next poll? Okay, so I think there's some technical issue. We can't share the poll. So let's
just discuss it.
let's have
discuss.
a discussion. So Professor Papasaurus, you first.
Well, this is a complicated case for sure. And I believe that because of the big stone burden, especially in the ureter, if it's feasible, you could go both ends. So do a percutaneous access from the antegrade part, and from the retrograde part go with your flexible instrument. So theoretically, you could go from both ends. We shouldn't be afraid of the of the pelvic kidney because it's accessible to percutaneous access. Of course, experienced cases. So from all these 4 options, I would go for the 4th one.
Okay, would this small, rather tortuous ureter We know that there is data about pelvic kidney and RIRS. Would you have any issues? Would you like to stent him first, if it is possible to pass a stent with these big stones in the ureter? Or would you go in directly? This is a short, bit tortuous ureter.
You cannot easily pass JJ stent without laser in the stones. So, I mean that if you can get in, you go ahead with the laser in the stones from below. So I don't believe that the ureter is an issue. It's the fact that it's not so easy to go through this Steinstrasse.
Zafar, what would you do?
Well, I think the problem is the kidney is quite low down in the pelvis, and perking it it's not going to be that easy either. The other thing is that there's a big stone sitting and obstructing the kidney, both at the lower end, at the upper end as well. So I would go from below and do the RIRS, try and clear out my passage up to the kidney. Once I'm in the kidney, and then depending upon how things are, then maybe do a puncture from the top and remove that stone if my scope doesn't reach the flexible scope doesn't reach the lower pole stone. If it is, then fine, I'll just continue to do the RIRS and clean it off from below. But if I can't, then I would certainly clear the ureter and then puncture it from the top and actually take the rest of it out.
Right, thank you. I think it's quite obvious from the discussion by the experts that these are difficult situations and there are no guidelines and there are no clear indications of how to go about in these situations. But if you look at the data, I agree with Professor Papasaurus that Arya and Zafar Zaidi, that flexible ureteroscopy is perhaps the best way to go about, particularly with significant Steinstrasse that we have. So you do need to go from below to clear the track. Okay.
So the one more addition to it, and obviously this case has nude written all over him. What if you can't get in from below because there's a big chunk of stone sitting at the UO? In fact, looks like it's sitting in the bladder. Then what would you do? I mean, I would in that case try and put a PCN at this stage because the patient is in trouble. And you do need to decompress the kidney. If I can't get in from below at all, then I would put in a needle and put in a PCN and let the kidney settle down, and then try and get in from use that as a track to go in later on.
Dr. Karye, what about open surgery in a situation when you have difficulty in retrograde access?
If we will perform the open surgery, we under the risk to get the infection first, and the nephrostomic tube we will give to our patients for all our next life, because it will be difficult to remove nephrostomy after the open surgery.
May I comment, please?
Yes, please go ahead, Thanos.
Yes, to be honest, open surgery is a contraindication, and I'm happy that it's not included in the answers, because you'll end up with reimplantation of the ureter at the end. We have many stones in a short tortured ureter, so I believe that it's a last resort. Because the pelvic kidney is hugely dilated, I believe that it's easy to access it percutaneously. If you have issues with ultrasound, you can do it under the CT guidance, even after help of our interventional radiologist. So I wouldn't just put perk. I would go ahead with my antegrade approach. We know that in cases like in ileal conduit, you go ahead doing a flexible uteroscopy from above. So it's an option. Whatever you cannot do from below, you do it from above. You are forced to do it. Thank you.
Yeah, I think that's
And you can also do it laparoscopic assisted to make sure that there's no gut in between. And just keep your laparoscope, move the gut away, and puncture it just like you would. And it's a dilated kidney, surely.
right. Great, thank you. Can we continue with the presentation, please?
Well, the correct answer in this case is ESERS. At least that's what Trux's team was doing. This is the case of Olivier. So the next case is a 36-year-old woman, first stone former, no infectious signs whatsoever, not much symptoms whatsoever, and you see here with the white arrow pointing to a 5mm stone. What would be your treatment options? This is the contrast picture on the left. It's an upper ureteric stone with hydronephrosis. So you could do shockwave treatment, you could do percutaneous treatment, you could do retrograde treatment, or you could simply wait and watch. What would you do?
Okay. Well, I am disappointed at this. Such a gross hydronephrosis. There's a large number of people who want to wait and watch. Maybe we have missed something here.
Also, ESWL is not an option because we've got an impacting stone.
Yeah.
So I believe it is a tricky case where you just concentrated on the size of the stone, 5mm. And I always say to my residents, why 5mm stones is stuck there? So if you've got an upper ureteric stone, regardless of the size, if you've got hydronephrosis, you have to decompress the system. You have to either put a JJ stent or go ahead with rears. Don't do ESWL. Don't just wait and watch. It's a problem to do so. Thank you.
Yeah, I mean, impacted stones, this is what you have, irrespective of the size. There is an issue with impaction rather than anything else. Significant mucosal edema that what you will see if you do ureteroscopy. Right.
And that's why just to add the comment, that's why now there are studies where we measure the ureteric wall thickness. And if you've got great impaction, the ureteric wall will be quite thick. And we take this into consideration to decide to do invasive operation and not ESWL. So ureteric wall thickness would be big in this case.
Yeah, I'm very disappointed because people have completely missed how badly the kidney is acting. It's very grossly dilated. There's hardly any contrast in it either. I mean, we can't wait and watch. That is one thing we cannot do. You know, it's either if this kidney is gone, if there's no function, that's another story. And again, you will have to do something about it. Otherwise, I think the wait and watch is certainly, and there's a very large percentage who've answered that. I think then there's something that we have missed in our teaching here. There's something is very serious here.
Right. Let's move on with the presentation.
Well, the correct answer is actually both, but of course not at the same time. So we tried ESWL first. Upper ureteric stone, 5mm. It's a clear-cut case. If you have ESWL in your clinic readily available, it is certainly a viable option in the absence of infectious complications. A retrograde intrarenal surgery as an initial treatment would be acceptable today as well. This case is before the area of flexible ureteroscope stone. So we tried ESWL 4 times without success. It just didn't work. And then we attempted a retrograde URS and we couldn't reach the stone because the ureter was terribly kinked. which you can't see on the contrast, of course. The stone was impacted and the passage was simply not negotiable. So this patient was lost to follow-up for 1 year for no specific reason. And when we saw her again after 1 year, she had a severe pyelonephrosis and loss of kidney function, and she ended up with a laparoscopic nephrectomy. So the morale of this story is that there are no straightforward, simple cases preoperatively. We will only know afterwards. A 5 millimeter, seemingly small, uncomplicated upper ureteric stone ended up with a pyelonephrosis and nephrectomy.
Classical mistakes.
Now, this is a case of a 71-year-old male, has a bit of vague abdominal pain, bilateral hydronephrosis on ultrasound with dilated ureters. And as you can see here on the KUB, there is a 4 by 3.5 centimeter stone in the distal ureter on the left. On the same side, we have a partial stack-on stone and some smaller stones, and then we have a right distal ureteric stone, 1.5 centimeters in diameter. Surprisingly, the creatinine is normal or very slightly elevated. So this is the contrast picture. On the right side of the patient, you can just about make out a hydronephrotic kidney with a wide ureter, and the left side is quite clear. So what would be your initial immediate treatment in this patient? ESWL, URS, right nephrectomy, or a bilateral double-J stent?
Okay. Okay, nearly half of the participants have voted. Maybe 3-4 seconds more and we can stop the poll. Okay, I think we can end the poll now and share result. So we have, Safar, you must be happy now. They have learned the lesson, and Professor Papasaurus as well, that no lithotripsy this time. And obviously nobody has opted for nephrectomy. So Dr. Karyev, any comments on these choices?
This patient will be very lucky patient if stents will go through the stones. My opinion, if we have the level of creatinine slightly higher, first we should prefer the percutaneous nephrostomy. And in the next step, when the function of kidneys will be good, we can perform the ureteral retrograde ureteral lithotripsy endoscopic method.
Professor Papasaurus, how do your patients in Greece take external tubes like a nephrostomy? Or would they rather prefer an internal stent?
They hate it because they cannot control it. I mean, it's very difficult to have a nephrostomy because that means that you need to have someone that will look after it. So only as an emergent solution, we would keep a patient for a few weeks for the nephrostomy. But they wouldn't bear to have this.
Thank you. Can I ask a question?
Yeah,
with this contrast study showing the left side seems to be draining pretty well, not extremely dilated, and right side grossly dilated, the draining. What I mean, and you go in and you can't get a double J stent on either side. What would you do?
well, I would probably, if he's not infected, his CRP is normal, I would probably just go and do an internal ureterotomy, have this stone delivered into the bladder, and it's much easy
The left one?
Yeah.
And what about the right one?
The right one can be taken care of by ureteroscopy.
Right. But if he is infected, then the right PCN certainly would be a requirement.
Yeah. So I think we running out of time, and any final comments, any messages, Professor Papasaurus, for the residents who start to see these difficult patients in their early endourological experience?
You should act step by step. Decompress the system, try to put your JJ stent, and you can do a stage operation. There's no rush to give the final solution with only one operation. It's better to be on the safe side.
Professor Zedi.
Yes, I completely agree with you, with the professor here. You need to be aware of what is available. Your investigations should be adequate to give you the correct anatomy and the function, of course, but certainly the correct anatomy if you are planning endourological procedures, so that you are not sort of stuck in a position where you don't know what's happening next. And step by step, there's always, very rarely are there emergencies. Mostly these are elective cases. If you get stuck in, at any stage, you can bail out, come back in, and do something later on as well. So don't be too heroic in one go.
Dr. Kariev, any messages?
I hope the patients will be very, very happy when they will free from stones. In this case, we should be hurry. We should operate in cold period when the function of kidney will be good and creatinine level will be normal.
Thank you very much, and I'm really grateful to our three learned panelists. Thank you very much to Dr. Papasaurus again for taking time out from his busy schedule. I know this was a busy day for him. It is a pleasure to have him, and I hope we hope that we see you again in our academic activities. So thank you very much, all three of you gentlemen, and have a nice evening.
Thank you.
Thank you, and tomorrow we start again at 1 o'clock.
We have one more presentation to go. There is a case discussion on urethral stricture disease.
That's right.
And Dr. Imran Jalbani from Aga Khan Hospital is going to present the cases. And we have three of our experts in stricture disease, Dr. Ahmed Fawad, Professor Manzoor Hussain, and Professor Aziz Abdullah, to take up these cases. So Imran, are you ready with your presentation? Imran, are you there?
He's muted. That's the problem.
Yeah, Imran.
He's ready. Yeah. Imran is ready, but he's muted. He needs to be unmuted.
Yeah, thank you. Thank you, Dr. Ahmad. Can you listen me?
Yeah, we can hear you now. So
yeah,
please.
Thank you, Dr. Ahmad. Yes, I'm ready.
Yeah, please go ahead with your presentation. We can't hear you, Imran.
I think Dr. Imran is here again.
I don't see his audio on, so although we have moved a long way from those carousels and presentations getting stuck, but technical problems, even these.
Yeah, thank you, Dr. Ahmad. Sharif, kindly move forward. Next slide. Yeah, so for resident, this graph must be well known in the Campbell's, as you know, that small iris structure, then there's a full membrane, then this structure goes ahead with the fibrosis, which involves spongiosis and sometimes cavernosis as well. So failed urethroplasties, triple hypospadias, and pelvic fracture and distraction injuries are something which are complex urethral structures. Next slide, Sharif. So this is algorithm which is there for anterior and posterior urethra. We all are familiar with. Sharif, next slide. So this is an interesting case of 53-year-old gentleman who does not have any known comorbidities apart from a stricture, and he is having a history of a multiple DVIU and one failed urethroplasty, which was anastomotic. Now he presents again the clinic with a poor flow with a maximum flow rate of 6. Post-wide residue, there is nil. There is a leaking of a urine from a ventral surface of the penile shaft. There are 2 openings. Next slide. So this is a ureterogram, which we can see that entire penile urethra is involved by a stricture process, and there are 2 out pouches and likely diverticular, and there's a tight stricture, spinobulbar junction. So I think my senior panelists are there. So Dr. Aziz, so next slide. So this is a complete anti-urethral stricture with multiple diverticuli. Dr. Aziz, what do you think? What is the management option here? That is urethroplasty. So what approach do you think should we go ahead with?
I think he will need a urethroplasty, but it's most likely going to be a pan-urethra involvement. So either buccal or bladder mucosal involvement. Use a graft for the bladder or buccal. I think we have to reconstruct the whole urethra. So sorry, I missed what was the age of the patient?
So he's 53. Dr. Aziz, he is 53, gentlemen.
He's a fairly young patient.
So what do you think, Dr. Aziz? This is a very long stricture, almost 8 centimeters, or maybe a little longer than that, and very small and narrow caliber urethra. So how to patch a buccal mucosal graft in that, I mean, a one long piece from one side to another side, or 2 pieces? What do you prefer?
May I comment if the sound is not there?
Yeah, please, Dr. Ahmed, please.
Well, this is probably one of those cases where you can have what you would prolapse the penis back into the perineum, and the Kulkarni technique, that you would go and you could use buccal mucosa or bladder mucosa depending on what length you measure on the table. So you don't always need to have one long graft going all the way through. You can also do the grafting piecemeal. Now, this is what has currently become more popular. But historically speaking, if this patient does not have XBO, then local penile skin is a good graft option, and you could consider an Orandi's flap, which is a local flip-flop closure of the entire length. I wish there was a picture. I don't know whether you have you have one of those operative pictures later on, but you can do an Orandi's flap in this particular patient.
So, Dr. Ahmad, the urethral meatus is perfectly fine and there's no hypopigmentation. So
Right.
this is classic, yeah. So
right. So Orandi's flap is one of the options.
And he's
other than
circumcised.
Other than
Still, you will consider
a Kulkarni style buckle or bladder grafting.
Okay. So will you complete this in a single stage?
Single stage. Either
Okay.
of the procedures
Thank
in a
you.
single stage.
Okay. Sharif, next slide, please. So this is a 46-year male, again with lower tract symptoms, mainly poor flow, and his Qmax was around 7. Straining. On examination, there's a hypopigmentation of a glans, classic BXO with a very narrow meatus. And when we got ureterogram done, Sharif, next slide. This is how it looks like. So entire penile urethra with meatus involvement, and stricture length is around almost 7-8 centimeters.
Kindly unmute.
So Dr. Manzoor, are you there?
Kindly unmute him. Make him the co-host.
Sharif, Dr. Manzoor, mute हुए.
किस नाम से डॉक्टर मंजूर सर?
SIUT.
SIUT.
Dr. Manzoor, this
Yes.
is probably you listen the history. Should I
Yeah,
repeat it?
yeah. No, I've listened the history. So this is a case of lichen sclerosis, BXO, and involving the whole anterior urethra. Am I right?
Yes. So how will you proceed for the in terms of a management purpose?
Okay, so I think in this case, I would like to go for the combined dorsal inlay and ventral onlay, because the distal urethra is very narrow and less than, I think, 5 mm. And also the mid urethra is also very narrow. So the best option as a single stage in this case will be the combination of dorsal inlay and ventral onlay BMG urethroplasty, because skin cannot be used in this case.
Right, I agree. There is one thing which is very challenging in this, and that is having a good patent meatus subsequently. The meatus part is the most challenging in such cases that I find.
Yeah, Imran, meatus is narrow or meatus is open? Because BXO, in the BXO, it's a skin disease that involves the meatus first. And then the patient, the void against the obstruction, and there is intravasation and the other urethra is involved. So meatus must be narrow, I think, in this case.
Dr. Manzoor, in this case, meatus was hardly 1.5 millimeter.
1.5.
Sharif, can you move? Sharif, can you move to next slide? So, Dr. Manzoor, my question was here that you were probably saying about a super technique, putting graft ventrally and dorsally as well in a combination of the two techniques.
Combination.
Am I right?
Yeah, that's right. That's right. I personally feel that this will give the good results rather than giving a single dorsal inlay or lateral onlay, as you have suggested, Kulkarni. So I think in this case, the combined technique, the dorsal inlay and ventral onlay will be maybe more effective and more successful in this case. Because the meatus and the distal urethra and middle urethra seems to be very, very narrow, and less than 5 mm maybe.
Would you like to comment on the reconstruction of the meatus? on this one?
Meatus, we can go for meatotomy and then do meatoplasty, V-shaped meatoplasty. And dorsal inlay incision can be extended up to the tip of the meatus, okay? And so in this way, we can enlarge the meatus and make it V-shaped in the end. And because meatus, if gets again obstructed, then it can cause recurrence. So the dorsal inlay incision can be extended up to the tip of the meatus and putting the graft after dissection and placing a graft in the raw area in the dorsal inlay fashion, and then another graft for the ventral onlay. BMG will be, I think, will be the answer in this case, which can be maybe a curative. Otherwise, other option, like you have said, that dorsal meatotomy and Kulkarni is another option. Or two-stage is, as you have said, two-stage is reserved for those patients where there is a total loss of the urethral plate. But in this case, the urethra seems to be patent in, and so I think we should use the urethral plate and give dorsal inlay and meatoplasty and ventral only combined technique. This is my opinion about this patient.
May I comment on this?
Dr. Aziz, are you there?
Aziz, are you there?
Yes, I'm here.
Yeah.
Right,
And,
okay.
I think for the meatus, best thing to do is put a dorsal graft that you make a incision into the meatus and put a V-shaped graft over it and extend that sort of a SOPA down to that.
So Dr. Aziz, you mean a iatrogenic sort of hypospadia creation?
No, not hypospadias. You mobilize,
Movement of,
like you do in a Kulkarni. Mobilize it completely, open it dorsally and put a graft extending right to the tip of the meatus.
Yeah.
Okay. Dr. Aziz, do you prefer closing the harvesting site or this subject is over?
No, initially when I started using buccal mucosa, I was closing it and stopped closing the harvesting site because it's painful. It does not make much of a difference. Post-operatively, the patient is much more comfortable and usually epithelialized within 24 to 48 hours. So it does not make much of a difference whether you close it or leave it open.
Imran, can I have some comments?
Okay, so
hello.
Please, sir.
So if you I have seen few cases of bleeding after harvesting and leaving it unclosed or open. So what happens that if you are an experienced surgeon and you have done a good hemostasis, then it's okay to leave it open. But if you take a large graft, like in this case, you need, I think, large graft. So I think it's better to close the this harvesting site because it can bleed. And I've seen at least 4 cases in my last 3-4 years, bleeding and coming in emergency.
I think you have to be very meticulous.
After 10 days. And one patient came after 10 days of this, harvesting. So if patient is
Dr. Ahmad
outside Karachi.
Yes, I would, I'd like to make a comment here. I have, my practice is the same that I used to be closing to start with, but I have stopped closing in spite of the fact that I've had 2 bleeds. But Dr. Manzoor is doing probably 10 times or 15 times more cases than what I am doing. So having 4 bleeds, I wouldn't worry so much because one of the bleeds was very problematic. It was at the far end, and to get the bleeder there was a little challenging. But all having said and done, the morbidity with closure and the pain with closure is far more than leaving it open. So I would still go by leaving it open.
But I think
I agree.
If patient belongs to, for example, far-flung area, and if he bleeds after 7 days, then this can be a real emergency. And I think So this should also be considered, that if you are experienced surgeon, if you have done many cases, then it's okay. Otherwise, if you are a learner, then I think we should close it as a beginner, for especially in those cases where we are taking large graft, like in this case, maybe 8 centimeter or 8 centimeter. So for beginners, I think it's better to close. But if you have enough experience,
Dr.
and
Ahmad.
if you,
Yeah, I mean, I agree with Professor Fawad and Aziz Abdullah that the issue with closure is that no sooner you start to use your oral cavity and eat something, those stitches do not hold. So, so leaving that site open, personally, what I do is I raise the mucosa with a little bit of lignocaine with epinephrine. That has two advantages, that it raises the mucosa and it leaves very little fat with it. So it's easy to take that graft, and post-operatively it doesn't bleed that much. And maybe you can, epinephrine soaked gauze is left until you put this graft and you take it out. I only have one case of bleeding, and that patient had a very rare factor deficiency. The rest do very well, but I know Professor Manzoor has a huge experience and patients of various categories. So I think it's an interesting experience shared by three experts.
Dr. Ahmad Fawad, probably you're saying something.
Yes, the same thing. I think what Professor Manzoor, because he sees a variety of patients who are coming from distant places, and they are probably not staying back here, going back. So there, being on the safe side for a beginner is more important than otherwise. But if you have patients locally, I'm sure he also has the practice. For local patients, he may not be doing the closures, but for those who are distant, you may. Am I right, Manzoor?
yeah, that's right. That's right. Yeah.
Yes. Thank you. Sharif, can you move to next slide, please? So this is pretty straightforward. 41 who had history of a stone passage around a year back with a few episodes of hematuria, and now he comes with a poor flow. His Qmax is 5.6, PVR is 25 ml, and the urethrogram shows a small stricture at pino-bulbar junction. Sharif, next slide. So this is otherwise a simple case. How many of us would go ahead with a DVIU? Dr. Aziz, would you think this is a case for the DVIU versus non-transecting urethroplasty? Probably there's a sound issue. So, Dr. Manzoor, can you answer this?
Because at our center we have a laser, so now we are doing most of the cases with laser, and the advantage of laser is it can be done in a patient who are on anticoagulants or bleeding disorders. It gives a very clean and precision of the procedure, which is not with the DVIU, and you can have a circumferential ablation of the stricture. So in my experience, although the reported the literature say that the results are equal, but with the experience, I think in a non-stable strictures, the laser gives the better results than the DVIU.
Okay, next slide, please.
Dr. Manzoor, what is the mean recurrence rate after laser?
6 months. At 6 months, there was we have compared the DVIU with the laser. So with the DVIU, there were 23% recurrence rate, and in this case, it was about 10%. But I think it depends on the selection criteria. It's not good for those patients who are completely obliterated or with stable injuries or something. But idiopathic strictures I think personally, if you do circumferential ablation, this laser gives the better results in my experience.
What about, do you have any experience of injecting?
So,
sorry. Any paclitaxel or mitomycin?
Dr. Aziz, please
into
carry
the
on.
picture?
No, I have not done any this antibiotic injections for the prevention of recurrence. I have got no personal experience, but we are planning for the optilium dilatation, balloon dilatation in the future.
May I comment here?
Dr. Ahmed, please.
Yes, say, you see, if it's the first time the patient is presenting and the history is it is because of passage of stone, there's a great probability that he just has mucosal injury and mucosal narrowing. Now, these are strictures because we have to qualify. If it's a straddle injury or if it is one of those, then you are looking at variable results depending on how deep the injury has penetrated and caused the scarring. But for stone passage, almost always you'll be finding it's mucosal. So it's worthwhile doing a urethroscopy, and that gives you a pretty good idea there. So giving him one DVIU or a laser DVIU, depending what you have at your center, is what you would do. There's a comment here about self-catheterization. If anybody is needing a self-catheterization, that means your treatment is a failure. So self-catheterization is only for those who are not fit for any other
Dr. Ahmed.
Fawad, I don't agree with that. I don't agree with that. My practice has been, if I do a optical ureterotomy, all patients are taught self-dilatation, and they do it over the decreasing pattern. They start from doing daily, goes on to alternate day and so forth. And that's my standard practice and been for quite some time. And in that way, you don't get much of a recurrence.
Achha, I have somehow never practiced self-dilatation for self-catheterization for patients. So I will be short on commenting on that.
Can I say something?
Please.
I was, advising somebody for after DVIU, the CIC. So the reply of that patient was that if, I have to do the CIC or if I have to do the catheterization by myself, why should I come to you? So please give me some curative intention or curative this treatment. So this is not a curative, this is a palliative treatment and should be reserved for those patients who are not fit for any urethroplasty or any other thing. So I think this DVIU followed by self-catheterization, you have shown the better results, but it's not a natural, method or the optimal treatment for the stricture. We should opt for something which is curative without any. The CIC can cause this urethral damage and can UTI and can cause further injury because it's not a natural method of passing. So I think we should give them a better option rather than unnatural option, except for those patients who are not fit for urethroplasty. We can
but
have.
Then Dr. Manzoor, the ideal treatment is to do a urethroplasty on them, because all other with optical ureterotomy or a laser, all have a failure rate.
Yeah, so I think if there is a recurrence after DVIU, maybe one recurrence, then we should opt for the urethroplasty. That can be curative for him at this stage. I think this is my view about the self-catheterization.
I mean, that's the way that I would suggest to do one, maximum maybe two if the patient insists. Otherwise, if one is a failure, then go for a non-transacting urethroplasty. But that's Aziz, I had the impression that you are doing much more non-transacting urethroplasties than DVIUs now. Is that correct?
Yes, I think we are doing very few opticals at the moment. We are doing going more for what normally I do. I offer the patient choice of either doing a urethroplasty or offering them optical ureterotomy with intermittent self-dilatation. Because my experience is that if you do just an optical, in most of the cases, you'll get a recurrence. Maybe 6 months, maybe a year. but the recurrence rate is nearly 100%.
So,
That's right. That's right.
yeah. So, Dr. Hamad, one thing, what is the message for the junior residents from this case?
Well, I think it's a very interesting discussion by the three experts, and the evolving experience that optical urethrotomy is for a very select group of patients with very small strictures, and it works, that's fine, but if it doesn't, don't waste any further time unless patient has medical conditions which makes further reconstructive treatments difficult. As for the experience of use of laser versus a cold knife, we have been using laser, but my personal experience is that the bleeding is less. Sometimes people have dysuria after this, but by and large, there is not much difference. The only thing which is different, and Professor Manzoor can comment because he has big experience in use of laser and he has been doing it for a very long time, is that you're more precise in terms of your excision.
Yeah.
And you're more circumferential excision of the stricture rather than what we do for optical urethrotomy, in which you cut the incise at 12 o'clock or 6 o'clock position.
Yeah, I totally agree with Dr. Hamad that there's a precision of incision and clear vision. And I think I have not seen in the recent practice, I have not seen any case of post-operative sepsis after laser, and no bleeding at all. So I think especially for those patients who are on anticoagulants or having got any bleeding disorder or who are not willing for urethroplasty, then we can offer them for laser.
Do you do it under, for up to bulbar strictures, do you do it under local anesthetic or?
No, general anesthesia or spinal, but not local. But some patients, some people, yeah.
Yeah, we have shared our experience, and this is an article published in Journal of Urology some years back, in which I do it under pseudoanalgesia with a spongiosal block. So you inject 1.5 to 2 ml of diluted lignocaine in the carpus spongiosum on the glans penis, apply a tourniquet at the base of the penis for about 3 minutes, and then you have a totally anesthetized urethra, and you can do optical as well as laser urethrotomies going right up to the membranous urethra without any discomfort. It's after membranous that you do not have a insensate urethra, and that causes pain. So for particularly for old patients in whom anesthesia is an issue, that's another thing that you can try.
Yeah, I think it's a good suggestion. Yeah.
Thank you. And as described by all panelists, that there's no difference between recurrence rate and short-term recurrence of a stricture between laser and optical. Sharif, can you move forward? Next slide. So another case of the 29-year male with poor flow, incomplete voiding, and we got a history of STI, which was around 18 months back, which was treated adequately. Now he comes with lower tract symptoms. Next slide. So the ureterogram shows again a pinobulbar stricture. It is, I think, length has been included with the multiple beaded appearances of urethra because soft strictures. So Dr. Ahmad Fawad, how will you proceed with this case?
Right, that is interesting in the sense that many times the concentric rings that you see on a ureterogram, the slight indentation may only be concentric rings and not necessarily what do you call a stricture. So what definitively sees like a stricture here are two sites. If you see on the descending, there are two distinct narrowings which has got proximal dilatation. So that is one reading that I would be taking out of this. Now, bulbar urethra, quite comfortably, you could do an end-to-end anastomosis, but bulbopenile, you are just on the margin. So you'll have to make your judgment depending what sort of a genital anatomy the patient has. If he has a nice, a good size genital anatomy and a good size urethra, you could still consider an end-to-end anastomosis, or section anastomosis. On the other hand, if that is not so, then you'll need to go with a dorsal graft buckle.
So Sharif, can you move to next slide? So Dr. Aziz, do you think that the ureterogram is enough investigation for staging a stricture, or you always do a cystoscopy before even proceeding with the urethroplasty?
And most of the time, ureterogram to begin with is not an accurate, totally accurate investigation to assess the stricture. You need some kind of other assessment also. I think you can do a cystoscopy, but you'll get just a view of one end. You don't know what's happening there at the proximal end. I think there's a lot of literature about doing a ultrasound scan. That gives you a better idea about what sort of a spongy tissue and what's happening in the strictured area.
So, Dr. Aziz, you're absolutely right in terms of anterior urethra. Yes, ultrasound has an addition to urethrogram and cystoscopy. So, in this, you will consider buccal mucosal graft or EPA.
May I make a comment on the investigation? I think what Aziz has just described, I've had experience of that in for earlier times that we were doing high frequency ultrasounds of the urethra with the urethra filled up with the KY jelly. So that gave you a distension and that gave you a good differentiation. And then you could also appreciate what was the depth of the stricture. So that is one of the ways of going about as far as this is concerned, the ultrasound.
Dr. Imran, can I say something?
Yeah, please, sir.
Actually, the definitive staging or the length can only be assessed during the operation time, because the sometimes urethrogram, even ultrasound is at its infancy. It's not in clinical practice at many centers. So actually, the length and the tissue quality can only be assessed at the time of operation. Sometimes the small stricture on the urethrogram can be very large stricture on the opening of the case. So I think all these things can be used for staging, but the actually staging the tissue quality and the length can only be assessed during the surgery or at the time of operation.
Entirely agree.
Yeah, I agree.
Thank you, Dr. Ahmed. Sharif, could you move to the next case even a couple of slides later? Move 2 more slides. Yeah, next even. Yeah, so this is a distraction injury of 26-year-old male who had RTA bike versus truck, run over injury to the left thigh, and open book fracture, as we can see an X-ray pelvis. Next slide. So complete defect, as we can appreciate on urethrogram, the length may be around 3.54 centimeter, but we cannot see the opening of a bladder neck. So next slide. Next slide. Yeah, complete. So Dr. Ahmed Fawad, how will you proceed with this case? What is the appropriate timing to intervene in this case?
Now, here's something interesting. I don't have a long experience of that, but I've done a case where the patient presented in an acute stage and there was an open book pelvis. Now, an open book pelvis gives you an ideal opportunity to give an incision and straight land up at the posterior. You've got the prostate and you've got the bulbar urethra there, and you could attempt a primary anastomosis, provided the orthopedic surgeons have taken a decision they are going to be fixing this pelvis. And that was the time that they had taken the decision that they're going to be fixing this pelvis with plates. And that is why we went in. And at that stage, it was a bit messy to find the healthy ends, because everything looked unhealthy, partly because of being bruised and partly because of being clots around. But this was a successful outcome in the long run. But otherwise, the standard of practice is that you would like to drain the suprapubic and then wait for things to settle down and then go as a delayed procedure.
So, Dr. Aziz, what do you think that what is appropriate timing of the repair in this case, when once patient is up and about, or maybe a 60 days or 90 days is enough?
I think usually wait minimum 6 weeks. I will not go near the patient before 6 weeks. And if the orthopedic people have put a lot of fixators, I'll wait for the fixators to come out before doing anything with this patient. Anything between 6 weeks and 3 months.
So, and what about the duration of catheter placement and pericatheter urethrogram? You still do it?
No, I normally I leave the catheter in for 2 weeks. That's been a standard practice. I don't know why. I've been doing it for donkeys of years now. I don't do a periuretrogram. I feel because if they, what normally they do when they put a dye in, they put a lot of pressure on the, and most of the time you tend to have a leakage at the anastomotic site, and then you end up with the problem of fistula and leakage and inflammation. So I prefer not to do it. I basically rely on my anastomosis and just wait and see. If I feel that anastomosis is not good enough, I leave it for another week, maybe 3 weeks.
Thank you, Dr. Aziz. Dr. Manzoor, what do you think? How will you get length which is required in this, and what is your first step apart from mobilization of a bulbar urethra? What is the next, and what amount of the length would you get from rerouting, from inferior pubectomy?
Yeah. So it's a perennial progressive approach. So we start with the step by step, and first, as you have very rightly said, that the first step is the mobilization of the bulbar urethra. It gives you 2.5 centimeter extra length, because as we know that the bulbar urethra has got curve, and if you make the curve straight, then it gives you extra length of 2.5 centimeter. And then the second step, if with the mobilization of bulbar urethra, the anastomosis is not tension free, then the next step will be to divide the crura. And in the crura, this deep dorsal vein is also ligated, and this will give you 1 centimeter extra length of which can be bridged. And if even with this this step, it's not tension free, then you can do the inferior pubectomy. And inferior pubectomy will give you 1 centimeter extra length. And if it is even not, then the rerouting is the another. And if it is still not having tension-free anastomosis, then transpubic approach or combined abdominoperineal approach is another method by which we can have steps to shorten the length. The idea is to put the bulbar urethra to the prostatic apex or any prostatic part in a straight fashion. So these are the 4 or 5 steps which one should go by step by step.
So how you find proximal end? You still like to cut on a light, or there's another thing which you go for removing a scar tissue and then look for proximal end?
Proximal end, we pass this flexible urethroskop or the rigid urethroskop, and then maybe cut at the light, or maybe bougie can be passed if it is, if you are an experienced surgeon, bougie can be passed from the suprapubic root and felt in the this perineum, and we progress our excision or the dissection by feeling the bougie. But sometimes it may be very proximal, and it depends upon the surgeon's experience, and it should be bit by bit excision and looking by a flexible cystouthroscopy. But it's important to the anastomose, the normal end to normal end, not the false passage to the normal urethra.
Okay, thank you. Dr. Ahmad Fawad, in
No, sorry,
urethral injuries.
before I go further, let me just, quite rightly, as what has been described, as far as the proximal side is concerned, it can be quite challenging. And progressively, multiple things have been done, both flexible scopes, rigid scopes, bougies, and even if if there was some continuity, because sometimes there's a total distraction, sometimes there was a partial distraction, and there is some continuity there, and a bit of dye is going in. In that case, if you put methylene glue on the top and you press, so you might see that at the tip, and that might give you an idea. So multiple things that you have to use as far as you're going to be doing that. One question I'd like to ask my other two panelists at this stage is, when you are doing an anastomosis, at one time, it was very much advocated to evert the lips of the prostatic mucosa, and you give an incision a little onto the dorsum of the prostate, evert the lips, suture them, and then anastomose the bulbar urethra. Do we practice this in your usual practice, or this is unnecessary?
So I always give the lateral fixation of the mucosa and eversion of mucosa. That gives the better results, I think. I personally feel.
I think need to do a proper mucosa to mucosa anastomosis.
Yeah.
That will prevent from having a restricting and process. Another thing is that I try to remove as much fibrous tissue as possible to clean all around it. So that's a very important, to clean all of the space where the urethra, proximal urethra is, to remove all the fibrotic tissues. That's very important also.
Yeah.
So it's important for the residents to note that these posterior urethral injuries patients do have an erectile dysfunction to start with. So it's important to take the history and document it. One can do it by a small questionnaire. Aziz, next slide, please. Sharif. Sharif, can we move? Next slide, I think that aspect is well covered. So I think this was the last case. So the take-home message for all those our junior colleagues is to stage the stricture with urethroscopy, cystoscopy, uretrogram even. This is a quality of life procedure. I think all the panelists can agree, and they will give us the final comments on this. This is a quality of life procedure. Everything cannot be corrected at every age. So know your limitation and choose the procedure appropriately. One by one, may I request Dr. Aziz for final comments?
I think it looks very easy. I think it should be selected, like you said, select a procedure. Master yourself in that procedure before going on to the next step. As I tell my juniors that start with end-to-end anastomosis, a straightforward, a short stricture anastomosis, try to perfect that before going on to venturing to our complex strictures. I think more जो वो तंग करने वाले स्ट्रक्चर होते हैं वो डिस्ट्रैक्शन इंजरीज वाले होते हैं. They're very sometimes you end up just वो bougie डाल कर उसे देखा है कि you just push the bougie out through the lower proximal end और उसके साथ just anchor it. Because होता ये है कि once you remove the catheter, दूसरे दिन patient goes back into retention and end of story. And so once you master yourself के local anatomy अच्छी आनी चाहिए, वो जब ही आएगी, then when you start doing a dissection and mobilization of urethra, और उसके बाद step by step approach. हर केस में कूदना पड़े, gradually बड़े cases में जाएं. Thank you.
इसमें I think one
Ahmad
other
Fawad.
thing, and I'm sure Dr. Manzoor and Dr. Aziz Abdullah would agree with that, is there is no one technique which is ideal for all stricture cases. So this you must know. People have written papers, that is more to publish papers, that they have tried to advocate one technique and try to prove it by statistics and everything, that that is a better technique. You should have a whole armamentarium of techniques in your hand, and you should also tell the patient that a lot of decision making will be done on the table and we can't give you everything beforehand. Counseling is a very important part of doing any urethral open surgery. OIU, probably that's a simpler, but for open surgery, a lot of counseling is important.
So I think Dr.
Dr. Manzoor.
Yeah, I think urethroplasty is an art, not a science. And as I agree with Dr. Fawad that one should be very much familiar with all the techniques, because one technique is not suitable for all the patients. So we should have many techniques, master all the techniques, so that we can change the decision. And sometimes decision is changed on the table. And other thing that the newer techniques like non-transecting urethroplasty and nerve and muscle sparing and the double face urethroplasty are the efforts which we as a senior person should do to improve the quality of life of these patients, like fertility, infertility, impotency, and the post-word dribbling, ejaculation. So we should not think of only uroflowmetry rates, but also other aspects of this disease, like the sexual functions, ejaculatory functions, and quality of life. So we should, choose a technique which should suit that patient. For example, younger patient, we should take all the steps to prevent this infertility caused by urethroplasty or the ED caused by urethroplasty. So I think we should have an overall, as a senior person, we should aim for overall those techniques which are now in evolution in urethroplasty, and we should aim to improve the quality of life other than the uroflow rates. Thank you.
So I'm extremely thankful to all three panelists for an extremely valuable discussion for our junior colleagues and all of us. And that's it from our side. Thank you, Dr. Hamad, for giving us the opportunity to discuss these cases.
Thank you very much to the panelists and to all the speakers that we have this evening. So tomorrow we have institutional rotation at 1 p.m. starting at 1 p.m. until 4 p.m. And
sorry, 2 p.m. So tomorrow is Friday, 2 p.m.
Yes, sorry, apologies. So 2 p.m. and it will be at SIUT by Professor Manzoor Hussain and his team. And they will be showing some cases of live-related renal transplantation. In the evening, we're going to be covering the pediatric urology. So very interesting presentation on some of the common pediatric urological issues. We know that most of our adult urologists have very little experience in pediatric urology. So there will be interesting talks on some of the common pathologies of pediatric urology that we see. So see you tomorrow. And until then, have a very good evening. Thank you very much to all of you.
Thank you very much, Dr. Hamad. Thank you.
Thank you.
Thank you.